Hello, I'm Donald McCauley, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today I'm talking to Kurt Stange, based in Cleveland, USA. Kurt, you've had a really influential career in family medicine in the US. Tell me where it all began.
Well, I think it began with Miss Kunzag, actually, my high school biology teacher. When I was a freshman in high school, she came on the announcements and said they needed people to take pictures for the yearbook. And so I went and did that for 4 years and joined a photography business. And that was going to be my career. I was going to be a photographer using film now, which now in retrospect looks like a really bad business plan. And I did that for a while and said, I like this, but I can't imagine liking this when I'm old, like when I'm 40. What would I really like to do? And I said, well, I'm actually liking this biology that Ms. Kunzag is teaching me as well. And I want to work more with people. What's that biology in people? So I should become a doctor. And a family doctor was just my idea of what a doctor was. So that's kind of where it started for me.
So tell me about the progression then, university, training, primary care. How did that work?
I applied to 17 medical schools and only got into one. And I was so happy to be there. I said, I'm not studying for an exam ever again. I'm going to every lecture, everything I'm going to think about how would a patient present with whatever this biochemical abnormality or whatever it was. So that's what I did in medical school. And it was clear to me this is what I was meant to be. And I went from medical school in Albany to Duke, did a family medicine residency, joined a private practice part-time while I went down the road to Chapel Hill to the University of North Carolina and did preventive medicine public health training. And I did that basically because I had to wait for my wife to finish her training in pathology. And I planned to become a rural family doctor. That's my identity as a family doctor. And kind of the fullest way to do that in the US is to do it in a rural area. But I'd gotten this research training as part of my public health. And that at the time was a particularly unique skill. And so I went to Cleveland and joined an academic practice, mostly saw patients, did some teaching to begin with, and just started doing little studies along the way of questions that came up during practice. And those are still some of my favorite kind of things to do. You don't need a grant. Maybe you get a few of your colleagues to help collect some data. Hopefully, you ask the patients what they're interested in, questions that really come up in the real world. You don't have to worry about what you're going to do with it. You're going to apply it with the next patient that you see. So I started doing those things and then started doing some bigger things along the way and was just fortunate to get to work with a lot of wonderful people that I learned a lot from.
Well, you did a PhD in epidemiology. At what stage did you do that, and how does that fit in with your research?
I was able to do that as part of my preventive medicine training, and I couldn't believe it. I was getting paid to go to school, so doing public health work and getting that. I actually started with two people, a pediatrician and a pathologist, who planned on getting PhDs, and I made fun of them for a whole year. I said, "Come on, you've already got an MD, get your MPH, and get on with your lives." And then, literally one morning after a year, I woke up and I was taking all these classes which seemed like remedial work for things I should have been taught in medical school and wasn't. And I was teaching epidemiology to the medical students. My little master's project had grown because I managed to get some funding for it. I said, wow, I'm actually doing the work for a PhD. So I should actually go ahead and get the degree, which gave them a whole year to rag on me because of it. So it was after my family medicine training, it was part of public health training. And along the way, John Fry, who's a family physician I had lunch with every now and then, he said, so it's entirely quantitative. He said, you ought to take a qualitative research methods course if you can. He said, I think there's something good there. I don't know much about it. So just on that, I went and found one in the catalog, took that, and it was so complimentary to have some narratives to go with the numbers that I was learning. And so that got me started. And basically everything I did since then is mixed methods, some quantitative, some qualitative. Along the way, actually, when I came to Cleveland, was doing a large study and needed some people who really knew about that and got in contact with Ben Crabtree and Will Miller, who were just writing their book on doing qualitative research, which just came on a third edition and it's terrific, by the way. Um, and so that was really helpful. So it was just after my family medicine training I got the PhD.
My goodness, you really have the whole toolbox between the clinical practice the epidemiology and the qualitative work. So then how did you bring that into your academic career and the career progression?
As I said, I started doing those little tiny studies that were just kind of one-off things. And then I had a group that was interested in improving prevention and practice. And we wanted to do a clinical trial because that's the strongest method, right? And we were going to do a clinical trial to improve practice. And then we said, we don't really have any good ideas about how to do that. Or the ideas that we do have that are good, someone else is in a better position to do it. So we said, let's see if we can just see where prevention fits into all the things we're doing in practice. And we noticed that most people trying to improve practice focus on one thing at a time, which is fine if you're only doing one thing at a time. But if you're a family doctor, if you're a generalist, you're doing a lot of things. And so we got the idea that when we're not doing one thing we're trying to look at to improve quality, maybe we're doing something that occasionally it's more salient and occasionally maybe even more worthwhile. So we started looking at it with the idea of competing demands. And we're thinking, okay, how do we measure prevention, what we're doing in practice? And remember, Jason Chow was taking off his fingers how you can measure things. You can do medical record review. You can look at billing data. You can do patient or clinician surveys. And he said, you could observe things, but you can't do that. And we all said, yeah, you can't do that. And then 10 minutes later, Rob Kelly said, well, wait a second. Why can't you do that? Can't you do what? Why can't we observe? Well, there's the Hawthorne effect. It'll change people's behavior. And who's going to let you come into the exam room? I mean, the patient's going to let you come in and direct observe the visit. So we had all these reasons. But I couldn't sleep that night. I said, that's it. That's what we need to do that might be a unique contribution. So we proposed a study called the Direct Observation of Primary Care Study and work with some of the local clinicians and use that to help develop a practice-based research network of the local family doctors in Northeast Ohio. It took us 2 years to get funded. It was not the usual things that were funded. And I'll spare you all the details of that, but that really led us to, we directly observed 4,454 visits to 138 family doctors and 84 practices, classified every 15 seconds of the visit into 20 different behavioral categories, and a big list of things that were or weren't done, asked the patients about it afterwards, asked the clinicians. Ben and Will, I didn't know them. They just joined as consultants. They ended up doing a lot of extra work on it. We had 2,000 pages of ethnographic field notes that 8 research nurses collected. Worked with the clinicians to develop a network. So we had this kind of top-down study and bottom-up things. And it was a 2-year study, 1 year in the field. And we published 70 papers off of that just because there were so many different things you could look at by having direct observed practice.
My goodness, that's an awesome piece of work. That's incredible. Now tell me, I'm interested in something else you've said, and that's you're interested in complexity. And I think I heard you quoted saying the world doesn't fit into square boxes and straight lines. Tell me about that.
It actually started during this direct observation study. Ben and Will were getting together to look at all these quantitative data and trying to make sense of it. And just a linear approach didn't work. And Will was visiting Ben, and Ben happened to have a copy of Margaret Wheatley's book on complexity on the coffee table. And they just started reading that out loud and said, this is how we need to look at this. The idea that practice, that health, these are complex systems. And if you push on one part, it affects things elsewhere. It doesn't change, and A leads to B, leads to C. Way the initial conditions are important. Things emerge that are hard to predict. So that at least we started using that as a metaphor, really, for analyzing and making sense of the qualitative data. And we have used that ever since. We got Reuben McDaniel, who's a business professor at the University of Texas, who's an expert in that, to join the team and to help us use that to make sense. And we've used that, continue to use that as a way of understanding things. Along the way, I'd say about, 10 or 15 years ago, I got a call from a social epidemiologist named George Kaplan, who's done some large community health studies. And at the end of his career, he was wanting to use complexity science to make sense of these big things affecting health, and particularly equity and inequities that we have in care. And he got together people that were modelers that did computational modeling, agent-based models, system dynamics models. with people that were doing on the ground work. And so I was fortunate to be part of this network on niche, etc., network on inequalities, complexity, and health network. And so we started doing some quantitative things as well. So I'm trying to do that a little bit more. Complexity science is a way of making sense of the qualitative data, looking at how things emerge, how the whole is often more than the sum of parts, and then lately doing some things with modeling, often informed by qualitative data, so that you can do in silico experiments and say, well, suppose before we spend tens of millions of dollars doing a big experiment, what if we did a model of that and looked at what would happen if we changed two or three things across this complex system? What might be the effects of that?
So we've talked about complexity and we've talked about qualitative work. But when we think of Cleveland, we think of, tertiary care, highly specialist stuff. And you've been trying to work across those boundaries. Tell me about that.
We need both people with a narrow view and a broad view. And we all go back and forth between those. It's really about the balance. But I think we certainly in academic centers, we tend to value the specialist more than the generalist work. I think in how we make sense of things, often in somewhat simplistic ways that don't really take into account that they're complex systems, that tends to lead us to not have a way of understanding, of making sense of what you do when you're putting the pieces together, how you're actually iterating between this big view and the small view. And that going back and forth is really important. The prioritizing function, what we do in generalists, is really underappreciated. We have Barbara Starfield's 4Cs. We have ways of describing our work. The idea of prioritizing doesn't come up. And maybe it's occasionally a little bit threatening to think about that. But if you have the broad view and you're looking at that broad context of the whole person, and you start with what a person comes in with that day, you drill down on that. Maybe you do that. Maybe that's the main thing, and they go home. But then every now and then, before they go, you probably step back and put that in a larger context. And you do that over time. This looking at what's most important in this moment, even if it's just small moments over time, there's huge value of that to that. And how we measure quality and how we actually support practice improvement, we're blind to that function. So in Cleveland, I've actually worked with the specialist systems, worked with the big systems to fund my work. Frankly, all the funding is mostly reductionist work. So I use that to try to study one thing narrowly, which is what people will value and understand. And then around the edges, try to look at, okay, we understand that piece. How do we put the pieces together? How does that part fit into a larger whole? Which is actually what we do with general practitioners and family physicians. We're always kind of looking at the parts. I mean, Ian really called it an acquaintance with the particulars. And then acquaintance with the particulars, and then with the larger context moving back and forth. There's magic in that, and we don't understand that enough. So understanding that more and trying to figure out how do we use that understanding to support some of the things that the system and people really need generalists to do is really what I'm trying to focus on it right now.
Now, looking at your work and the breadth of your experience, it's easy to understand how you brought that into your work as the editor. So you've done a tremendous contribution as the editor of the Annals of Family Medicine, 17 years. Tell us about that experience.
Being an editor was the last thing I wanted to do. I was really clear I wanted to contribute to journals, but it didn't look like a good a job that I wanted to do. And I was actually the representative for the North American Primary Care Research Group to the first meeting of the organizations that were sponsoring the annals. And I was going there, I had someone in mind I thought would be good. And I went to the meeting, and on the flight there, I started thinking about what this could be. And it was a unique opportunity. It was before really social media was out there, but I thought, well, the initial vision was a very narrow parochial US family medicine journal. That was the initial idea, the initial impetus. I said, well, what if we made it international and multidisciplinary? And what if we, rather than this small representative editorial advisory board, what if we got a broad editorial advisory board? And what if when we accepted a paper, we thought with the authors about for whom might this new knowledge be relevant, and how could we make that relevant? And so we could take that, we could then invite people to comment on it and then summarize those as a regular editorial feature and get some discussion going about applying it. So I went with those ideas to this meeting and kept trying to bring them up. And the person running the meeting was almost verbally patting me on the head. And finally, she said, "Those are very nice ideas, Kurt, but that's for the editor to decide. We're here to get the business plan right." I said, "Oh," and I was silent for the next half hour until the person running the meeting said, "Okay, the next order of business is to um, have a committee to recruit the editor. Kurt, would you be willing to chair that committee?" And I had this long pause, and I looked around the room, and a few people in the room had said, "You should throw your hat in the ring." I said, "No, last thing I want to do, really clear, I don't want to do that." And I just said, "Well, I think I shouldn't do that." And she said, "Why not?" And I said, "Well, I think I might want to be the editor." And people were just shocked. So long story to just say, I backed into it. But it's helpful. You need to have a certain amount of detachment to do from the outcome to do a good job at something like that. So the fact that I never really wanted to do it, I think ended up being my superpower. The real superpower was then getting a phenomenal team together. And I really thought I would do it as a startup, but we had such a great team and were able to have this interaction with the different constituencies affected by the research, try to evolve different opportunities along the way. And so it was a joyful thing to do for way longer than I thought I would ever do it.
Kurt, I know you're doing some really interesting work at the moment. Tell us about your current projects and what you're hoping to do.
Well, I worked for about 15 years in community health and equity, and now I'm really trying to get back to my roots as a generalist. I'm trying to advance understanding of what this generalist function is in healthcare. I think those of us that do this on a day-to-day basis have an intuitive understanding about that, but I think systemically it's not really understood. How do we actually integrate and personalize and prioritize care for whole people? The way we are trying to improve care is actually very reductionist, and increasingly it's fragmenting care and adding more administrative burden. I think that more and more we're trying to treat healthcare as a commodity, and that's a part of it, but a really important part that's being lost is the relationship aspect of that. So I think a lot of things we're doing are actually making things worse. And I'm really happy that about over the last 10 years, I've been working with a wonderful social anthropologist named Rebecca Etz. And together we co-direct what's called the Larry A. Green Center for the Advancement of Primary Healthcare for the Public Good. So we're doing a whole series of initiatives that are really trying to look at the mechanisms by which generalism works. We spend billions of dollars every year understanding the mechanisms for specific diseases, for cancer and heart disease. And nobody really thinks to try to understand what are the mechanisms, what actually is behind the scenes when we're trying to put care together for whole people. So a few years ago, we developed a measure of what matters in primary care. It's called the Person-Centered Primary Care Measure. And it's based on asking patients and their family physicians what makes a difference in their lives. And we have a whole series of initiatives looking at what happens when you try to focus care on what the patient and their family doctor say is important. We also have some other studies going on trying to understand why people seek care. What is it about the generalist function that provides value? And then how can we articulate a new vision for generalist care that leads us to doing more work to actually try to support what we do on the front lines, rather than trying to define primary care as a problem that we have to solve to do whatever the latest reductionist thing that pops into people's heads that they want to work on now. So that's kind of how I want to spend my last rest, at least in my professional life. I also have one last thing I'm doing. I'm working on a novel. I've been working on a novel that I'm doing a final revision of that tells some of the same stories in a way that I hope that ties into the heart as well as the head.
And finally, let me bring you back full circle back to family medicine. And that is because you're doing some work now with disadvantaged populations.
Yes, I moved my practice 15, 16 years ago from the academic center to a community health center. And that was at a time where I was thinking I wanted to work a little bit more at the interface between healthcare and community health and public health. So did that clinically by working at a community health center, and then tried to do more things that were more focused on the health of the community. And one of the big problems we have around the world, frankly, is our inequities. So try to do some work in that arena.
And the very final question, you were awarded the Morris Wood Award. Tell us what that meant to you.
Well, I knew Morris Wood, and he's a hero, I think, for many of us, just how he was very grounded in practice, used that grounding to bring people together to do research, to generate knowledge that was helpful to support that, and just the culture he created at the North American Primary Care Research Group meeting. So to have an award that's named for him was very meaningful. And um, I was at a NAPCRAG meeting once, and my colleague Robin Gottler saw me across the room. We've been trying to talk to each other for a few days, and I said, finally I got to talk to her. She said, "Sorry, Robin, I keep seeing you, but we haven't had a chance to talk." And she said, "Oh, it's okay, Kurt. I see you're always talking to people. These are your people here." So NAPCRAG people, people that care about generalism, that are family doctors, general practitioners, that do that work from different disciplines around the world, that really feels like my peer group. And I feel like we have a deep understanding about what's important and what we're trying to do. And people tend to be pretty egoless about it. So to have an award from that peer group was very meaningful to me, both for the fact that it's a name from Morris Wood and the fact that it comes from people in NAPCRAG.
I just love that description of NAPCRAG people are people. Kurt, thank you very much for chatting to me today. It's been fascinating. Thank you for the tour de force around your career and for some of your inspiration to so many others. Thank you very much indeed.
Well,